Premenstrual dysphoric disorder is a depressive disorder characterized by mood and physical symptoms that cause significant distress in menstruating women during the luteal phase of the menstrual cycle. Premenstrual dysphoric disorder is also known as PMDD, and it isn't a very known condition. In fact, it is very peculiar. It is indeed a new diagnosis in the Diagnostic and Statistical Manual of Mental Disorders. The new DSM-5 criteria for PMDD require a combination of symptoms that began in the final week before menses, started to improve in the days after onset of menses, and were absent in the postmenstrual week during the past year. Symptoms of premenstrual dysphoric disorder could be marked depressed mood, feelings of hopelessness or self-depreciating thoughts, decreased interest in usual activities, and significant distress or interferences with work, school, or even relationships with others. Prevalence rates for premenstrual dysphoric disorder. Just in the United States, approximately 70 to 90% of women in the reproductive age group complain of at least some premenstrual discomfort. Symptoms last on average 6 days and are most intense just before and after the start of the menstrual flow. Assortic somatic symptoms include breast tenderness, bloating, headaches, and pain. After intensive research, the population most at risk of developing premenstrual dysphoric disorder are those women who have a family history of PMDD and those women with a personal or even a family history of depression or other mood disorders. But it's important to note that any woman can develop PMDD. Potential causes of premenstrual dysphoric disorder. 1. The symptoms of PMDD have been ascribed to fluctuation of ovarian hormones, serotonin disturbance analogous to depression, somatic manifestations of unconscious feminine conflicts, maladaptive coping strategies for an aversive physical event, and culturally determined expression of women's discontent with their traditional roles in society. 2. The cardinal symptoms of PMDD are generally alleviated by serotonin-augmenting drugs, while worsening of mood symptoms has been correlated with diminution of serotonin receptors on positron tomography. There are 3 treatment options that I believe is best fit for the treatment of premenstrual dysphoric disorder. The first treatment option is cognitive behavioral therapy, which has been shown to help people with depression, anxiety, and other mental health problems that share symptoms with premenstrual dysphoric disorder. Researchers believe that CBT may help women control how hormonal changes throughout their menstrual cycle affects their thinking and mood. Studies have also shown that CBT can be as effective as antidepressants in helping to manage the disorder, and it may even be effective in helping restore emotional health long term. The second treatment option is interpersonal psychotherapy, and this is a time-limited, focused, evidence-based approach to treat mood disorders. The main goal of IPT is to improve the quality of a client's interpersonal relationship and social functioning to help reduce any form of distress. The third treatment option is acceptance and commitment therapy, and this is a comprehensive model of therapy that uses acceptance and mindfulness processes to produce greater psychological flexibility. ACT has proven effective with a diverse range of clinical conditions such as depression, OCD, and workplace stress.